Derek was 68, a retired engineer from Manchester. He had been diagnosed with COPD 6 years earlier, done everything his GP asked, carried his blue inhaler everywhere, and never missed a single appointment. When I sat down with his notes, I found something that stopped me. 2 hospital admissions in 18 months, an eosinophil count of 380 sitting in his blood result for 2 years, never mentioned, never acted on, and a treatment plan that had not changed since the day he was first diagnosed. Derek was not failing his COPD. His COPD treatment had simply never kept pace with him. And here is the part that concerns me as a doctor. Studies show that more than half of COPD patients in the UK are not on the treatment their current disease level actually requires. When I explain that to patients in my clinic, the response I hear most often is always the same. Why has nobody looked at this before now? I am Dr. Suman, a respiratory consultant in the NHS and private practice here in the UK. In 15 years of managing COPD patients, one thing stands out above everything else. Patients know their breathing test result. Almost none of them know what actually drives their treatment decision. And that gap costs people their lung function. And in some cases, far more than that. Today, I'm walking you through the 4 steps of COPD treatment, from where most patients start through to where the evidence says many of them actually need to be. Stay with me to step 3. There is a single number sitting in your blood results right now that most patients have never been told about. That number could completely change your treatment plan. A quick disclaimer before we go further. I am a doctor, but I'm not your doctor. This is for education only. If you are struggling to breathe right now, please call 999 or see your doctor immediately. Before we get into 4 steps, there is something most COPD patients have never been properly told. Without it, none of what follows will fully land. Most patients treat their gold COPD stage, mild, moderate, severe, and very severe, as their identity. But that spirometry number is not what drives your treatment. Something else does entirely, and almost nobody explains what that something is. The gold ABE classification. This is the real driver. Most patients know their gold stage based on the spirometry, 1 through 4. It depends on the spirometry numbers, how much air you push out in 1 second on a single test day. But that number measures airflow. It does not measure your actual risk. It does not drive your treatment. What does? Your ABE classification. Group A, low symptoms, no flare-ups in the past 12 months. Group B, higher symptoms, breathless, limited daily activity, but no hospital admission or exacerbation in the past year. Group E, 1 or more moderate flare-ups in past 12 months or 1 hospital admission due to COPD exacerbation. Either one places you in Group E. Here is what that means in practice. I have patients at gold stage 2, moderate on breathing test, who are actually Group E. Their spirometry looks better than some stage 3 patients, but their risk is higher and their treatment needs to be more aggressive. The stage is one piece of the picture. Your exacerbation history tells the real story. That distinction is what drives every step on the treatment ladder we are about to cover. So where does treatment actually begin, and where do most patients currently sit on that ladder? Because the gap between where they are and where the evidence says they should be is the single most consistent problem I see in COPD management, and it starts right at the very first step. Step 1 is the rescue inhaler is not a treatment plan. When most people are diagnosed with COPD, they receive salbutamol, a rescue inhaler, a blue puffer, something to reach for when the breathlessness hits. It opens airways fast. It is there for moments of need. But a rescue inhaler is not a treatment plan. It is a fire extinguisher. and living with only a fire extinguisher is not same as fireproofing your house. The problem I see consistently, a significant number of COPD patients who have been diagnosed for years are still using only a rescue inhaler as their day-to-day management. No long-acting bronchodilator, no combination therapy, just a reliever puffer they reach for when things get bad. For Group A patients who are genuinely stable, a single long-acting bronchodilator with a structured annual review is the appropriate starting point. But if you're using only a rescue inhaler and your symptoms are present every single day, something has not been reviewed that should have been. Which brings us directly to step 2. And this is where the treatment gap in the UK is most significant. Because if you have daily symptoms, breathlessness on the stairs, struggling with tasks you managed easily 2 years ago, what the evidence says you need is not what the most patients are actually receiving. For Group B patients, persistent breathlessness, reduced exercise tolerance, the evidence is clear. You need 2 long-acting bronchodilators working together, a LABA and a LAMA. Examples are Spiolto or Anoro or even Bevespi inhaler. A LABA or long-acting beta agonist relaxes the smooth muscles around your airways and keeps them open throughout the day. A LAMA, long-acting muscarinic antagonist, reduces mucus production and prevents the airway wall from going into spasm. Together, they keep your airways open and cleared constantly, not just when you reach for a rescue inhaler. The evidence behind dual bronchodilation is compelling. It reduces breathlessness, improves exercise capacity, and most importantly, reduces the rate of exacerbation compared to either inhalers used alone. Fewer days in hospital, fewer chest infection spiraling out of control. But here is the problem. Many Group B patients in the UK, symptomatic, struggling daily, are not on a LABA plus LAMA combination. They are on a single bronchodilator or still relying primarily on a rescue inhaler because their treatment has never been formally escalated. If your COPD gives you daily symptoms and you are not on a combination long-acting inhaler, this is the conversation you need to have at your next appointment. Ask specifically, am I on a LABA plus LAMA combination, not one long-acting inhaler? Both. We are halfway through, and step 3 contains the most important data point in this entire video. Before I go further, if any of this has already made you think about your own treatment, drop it in the comments. I read every single one. I also run a free lung health community, a weekly newsletter with practical, evidence-based information for people living with COPD, explained clearly with no jargon. The link is in the description box below. Now, step 3. Step 3 is where one specific piece of data changes everything about how urgently you need to act. This is the most underused tool in COPD medicine right now, and it comes down to a single number sitting in your blood results. A number most patients have never been asked about and most have never been told. For Group E patients, one or more moderate flare-ups in a single year or one hospital admission, 2 inhalers are no longer enough. This is where triple therapy is indicated. Triple therapy adds an inhaled corticosteroid on top of your LABA and LAMA you are already taking. 3 classes of inhaler working together. Combination products deliver all 3 in a single device. Examples in the UK are Trixio, Trilogy or Trimbo. Now here is what actually determines whether you need triple therapy. It is not just how breathless you feel. It is 2 specific things your doctor should be checking. First, your exacerbation frequency over the past 12 months. Second, your eosinophil count. Eosinophils are a type of white blood cell. In certain COPD patients, elevated eosinophil level in the blood are the biological fingerprint telling us your airways are being driven by a specific type of inflammation, one that responds directly to inhaled corticosteroids. The NICE threshold is 300 cells per microliter or 0.3 in some of your NHS blood results. Write that number down. Ask your doctor for it at your next appointment. The evidence here is not marginal. Group E patients with an eosinophil count at 300 or above escalated to triple therapy show clinically meaningful reduction in exacerbation frequency, fewer admissions, longer stretches of stability. But many patients who meet both criteria, Group E, history, or an eosinophil count of 300 or above, are not on triple therapy, either because treatment has never been formally reviewed against current gold guidelines or because the blood result was taken and nobody acted on it. If you have been hospitalized with COPD in the past 12 months or are having one or more flare-ups in a year, do two things at your next appointment. One, ask your doctor to confirm which goal group you are in, and two, ask for your eosinophil count. Those two pieces of information could completely change your treatment plan. Now, I know what some of you are thinking because I hear the same three objections every single week in my clinic, and each one stops patients from asking the questions that could genuinely help them. I want to address all three directly. Myth 1. My GP told me my COPD is well controlled and optimally treated are not the same thing. If you are avoiding stairs, shortening walks, waking up breathless, that is not controlled COPD. That is COPD that has been accepted rather than addressed. Myth 2. Triple therapy is for people who are really ill. I am not that bad. The decision to escalate to triple therapy is not based on how unwell you feel today. It is based on your exacerbation history over the past 12 months and your eosinophil count. One hospitalization places you in Group E regardless of how you feel right now. Myth 3. If my treatment needed changing, my doctor would have changed it. COPD is a progressive condition. Annual NHS reviews are often short, and most of the time, you won't be seeing your doctor. They do not always include a full reassessment of exacerbation history against current criteria. Knowing your own group and asking the right questions is not undermining your GP. It is completing the picture. But what happens when triple therapy is not enough? Because for a specific group of patients, approximately 30 to 35% of all COPD patients on maximum inhaler therapy and still deteriorating year on year, respiratory medicine has just moved in a way that has not happened before in the entire history of this disease. And it is available on the NHS right now. In March 2026, NICE approved dupilumab, the first biological injection for COPD available on the NHS. The Boreas and Notus trials showed a 34% reduction in moderate to severe exacerbation in eligible patients on maximum inhaler therapy. Not marginal, transformative. This treatment does not work for every COPD patient. The same eosinophil count we discussed in step 3, 300 cells per microliter, is the biological marker that determines whether you qualify. Which means knowing your eosinophil count is not just relevant to triple therapy. It is the gateway to the most advanced COPD treatment now available in the UK. A second biological, nipolizumab, is currently under NICE review. If approved in 2026, patients with uncontrolled eosinophilic COPD will have two biological options targeting different parts of the same inflammatory pathway. As a principal investigator running clinical trials here in the UK, including trials on next generation treatment for COPD, I can tell you that the standard of care has moved. The ceiling on COPD management is rising. The question is whether your current treatment plan has moved with it. Let me bring this back to Derek, because his story does not end where I left it, and the way it ends is the reason I make videos like this one. When I reviewed his full clinical picture, it was straightforward. 2 hospital admissions in last 18 months, Group E without a question, eosinophil count of 380, sitting in his blood results for 2 years, never mentioned, never acted on. He was on a single long-acting bronchodilator. He should have been on triple therapy at minimum 12 months earlier. We escalated his treatment to triple therapy. Formal, structured COPD review, pulmonary rehabilitation referral. He now knows his gold group. He knows what an early exacerbation looks like before it becomes a hospital admission. He knows his eosinophil count. At his 3-month review, he said something I hear far too often. I didn't realize I was supposed to be asking these questions. I just assumed if there was something better, they would have told me. This is precisely why I make these videos. So let me give you the complete picture one more time. Because 4 steps are only useful if you know which one you are on and exactly what comes next. Your 4-step action plan. Step 1. A rescue inhaler is not a treatment plan. If it is your only daily defense against COPD, something needs reviewing at your next appointment. Step 2. Group B patients. Breathless, limited daily activity. The evidence supports LABA plus LAMA dual bronchodilation. Both long-acting inhalers, not one. Step 3. Group E patients. 1 or more flare-ups in a year or 1 hospital admission. Ask your doctor to confirm your goal group and your eosinophil count. The threshold that changes your treatment is 300 cells per microliter. If you are using your NHS app, then the cutoff is 0.3 units, not 300. Step 4. If you are on triple therapy and still deteriorating, biological therapy is now available on the NHS. Your eosinophil count determines whether you qualify. If you are in the northwest of England and want to discuss your COPD treatment directly with me, I run a private respiratory clinic at Polmol Medical in Liverpool, Manchester and Newton Willows, and I do have some clinics at Cromwell Hospital in London. The link to book is in the description box below. Here is what I want you to hold on to before you close this video. A COPD diagnosis is not a ceiling. It is a signal. A signal to be more precise, more deliberate, and more informed about what is happening inside your lungs and what can actually be done about it. The patients who do best are not always the ones with the mildest disease. They are the ones who understood their condition clearly enough to ask for what they needed. That eosinophil count is not just a number on a blood form. For many of my patients, it is the beginning of a completely different chapter in how they manage their breathing. Please share this video with someone you know who has COPD. The patients sitting in the treatment gap are not unlucky. They are underinformed. And sharing this might be the reason someone finally has the conversation their doctor has not had the time to have. I am Dr. Suman Paul. Take care of your lungs. They are the only ones you have. If you want to understand how COPD actually progresses and the one phase where the data shows most of the irreversible damage is done, check out this video next. I walk through every stage and show you the research that changed how I manage this disease in my own clinic. See you on the other side.